Good morning, everyone. So next IC is keratitis demystified. So keratitis, as you all know, it's a global important cause of blindness, and many cases can cause a dreaded disease in many patients. So we'll take you through a spectrum of infective as well as non-infective conditions. First, Dr. Veena Balaji will be discussing on the systematic diagnostic approach of infective keratitis. She did her post-graduation from the prestigious All India Institute of Ophthalmic Sciences and did her cornea fellowship from there. Currently working as a consultant in cornea and refractive surgery at Chaitanya Eye Hospital, Trivandrum. Next topic will be by Nimmi Raj. She will take you through algorithmic approach of clinical diagnosis of non-infective keratitis or immune keratitis. She also did her MD ophthalmology from AIMS Delhi and subsequently did her fellowship in cornea and refractive and cataract surgery from AIMS Delhi. Currently working as a consultant cataract, cornea and refractive surgery services at Precise Eye Hospital, Trivandrum. Next, atypical keratitis and emerging corneal infection, which was to be taken by Dr. Sanjeev Srinivas. He had to leave because of some family emergency, so we'll be dropping that topic. Next, I'm myself, Dr. Sharath. I'll be taking you through the surgical strategies in case of keratitis. Last topic will be done by Ruchika Patnaik, but she's not available today. In place of her, Dr. Rashmi Kulatil will be presenting. So she will discuss on the recent advances as well as the AI in diagnostic tools in keratitis as well as management in the most modern era. So she also did her MD from AIMS Delhi and subsequently she did her fellowship from LVPI in cornea and refractive surgery services. Currently working in Ahilya Eye Hospital, Kollam. So I'll invite the first speaker, Veena Balaji, to take on the stage.
Good morning, one and all. Myself, Dr. Veena, cornea and refractive consultant at Chaitanya Eye Hospital Research Institute. Thank you, Dr. Sharath sir and KSOS for this opportunity. So, infectious keratitis has been labeled as a silent epidemic in developing countries, especially in the tropical latitudes, with an incidence as high as 113 in 1 lakh population, and its prevalence is rising every year. Recently, a consortium-led proposal suggested the designation of infective keratitis as a neglected topical disease among the other diseases like trachoma, onchocerciasis, and leprosy. Fungus is the predominant etiology, which comprises more than 50%, with Fusarium and Aspergillus accounting for more than 2/3 of the isolates. So risk factors from this study done by Chidambaram GD et al. In South India were mean age of about 50 years with male predominance, especially agricultural workers with lack of formal education. Preceding trauma was seen in 72% of the cases, with most common mode being vegetative matter. Ocular risk factors like blocked duct were seen, which led to pneumococcal bacterial keratitis. Diabetics were prone to fungal more than bacterial keratitis. So while approaching a case of keratitis, history takes a major role. You have to ask for history regarding recent use of contact lens, in especially cases where you're thinking in terms of pseudomonal or acanthamoeba keratitis, and trauma with vegetative matter in fungal keratitis, and exposure to any contaminated water sources, which should ring a bell regarding acanthamoeba or microsporidial keratitis. In recent history of any ocular surgeries, for that matter, it could be refractive surgeries or C3R. So clinical examination, visual acuity, intraocular pressures. Detailed adnexal examination should be done, including ducts and lid margins. And ocular surface evaluation of the fellow eye is very important to rule out any dry eye disease. Detailed corneal examination under slit lamp. In all cases of keratitis, you have to document the size of epithelial defect and infiltrates, and degree of stromal edema and DM folds, AC reaction, especially hypopion. You have to measure the level of hypopion, whether it's fixed or mobile, corneal vascularization, and if any associated scleritis is there, that should be documented. So clinical cues to a specific diagnosis, fungal keratitis, usually they are very fluffy with feathery margins, with presence of satellite lesions, and you can see endoexudates on the endothelial side with a fixed hypopion. When you come to a bacterial keratitis, will be in gram-positive cocci, usually they present with a well as a well circumscribed ulcer with a central clearing, and you can see the adjacent stromal edema with high cellularity and a mobile hypopion. In gram-negative bacilli, the picture will be more or less same, but you should look for thinning and impending melt in, especially pseudomonal keratitis. Investigation, the most important and the foremost investigation for keratitis is corneal scraping. And in cases where the patient has used contact lens recently, you can send contact lens cases and solutions as well for microbiological evaluation. And microscopic examination, grams and KOH is done immediately, and you will get reports within 15 minutes, which will aid you in the diagnosis, and culture sensitivity as well. So when the most important question is when to scrape. When are you supposed to scrape a case of corneal ulcer? All ulcers, irrespective of their size or the time of presentation, you are supposed to scrape before starting the antimicrobials. So tailor-made approach, a case-based discussion. So this is the first case. So 67-year-old diabetic lady who presented with history of redness and whitish opacity in the right eye since 1 week. So this is how she presented to us. So when you look at this clinically, you think that is a fungal keratitis. And as usual, we started her on antifungals after taking a scrape, which unfortunately came to be negative for any fungal elements. But still we, as a clinical diagnosis was that of fungal keratitis, we put her on antifungals. But then as you can see, the next visit, the ulcer progressed with the margins becoming more fluffier and the hypopion worsening. And to our surprise, we can see that the gram stain report showed, the culture report showed heavy growth of Aeromono species, which is gram negative. So that's when it rang a bell that it could be a mixed infection in this patient. So we put her on antimicrobials targeting gram-negative bacilli. So now you can see the ulcer started responding to the medications. The hypopion is coming down, the ulcer is responding, it's healing. And 6 weeks later, you can see that the cornea is scarred well. So from this, the lesson learned is while diagnosing patients based on clinical signs, the probability of differentiating between fungal and bacterial is less than 70%. So you should always go ahead with a simple corneal scraping, and microbiological evaluation is the way to go always. So next case is a 23-year-old female who is an occasional CL user. You can see this is how she presented to us. We can see that there's a wreath-like pattern with pinpoint infiltrates which rang a bell of nocardia. Scraping was negative for gram stain and KOH. No fungal elements were isolated. But then you can see the next day, we started her on amikacin and antifungals. Next day, the ulcer started progressing. You can see the infiltrates going along the path of corneal nerves. That's when it rang a bell of acanthamoeba keratoneuritis. So we did a biopsy since the scraping was negative. Unfortunately, biopsy was also negative for any acanthamoeba cyst, but due to high clinical suspicion, we put her on 0.02% PHMB, and this is how she started responding to the medications. And finally, 3 months later, we got a BCV of 6 parts. So even though there is no microbiological evidence, with sharp clinical acumen and detailed history always helps. So lesson learned number 2, even when there is no microbiological evidence, serial follow-ups and monitoring with high clinical suspicion also plays a major role. So this is a case 3, 23-year-old female who underwent PRK surgery. She came to us 2 months later with this clinical picture. You can see dry looking ulcer with kind of satellite lesions down there infronasally. We scraped her, but scraping was negative. We started her on antifungals with high clinical suspicion of fungal keratitis, but then she progressed. By then we had got, by day 3, we had got the culture report, which showed Bacillus cereus in this patient. So as soon as we started her on amikacin, the ulcer started responding. And however, in this clinical presentation, you can see that a melt has started coming in. So that's the point when we had started steroids in this patient, and subsequently she scarred well with a BCV of 6 3 weeks later. This patient, we had initially started her on cefotaxime. She didn't respond. When the resistance report had come, culture sensitivity had come, she was resistant to cefotaxime but sensitive to amikacin. As soon as we shifted her to amikacin, that's when she responded. So antibiotic resistance is often overlooked, and it's another reason for ulcer progression. So lesson learned number 3, identifying medicamentosa and managing it leads to faster ulcer healing. Timely steroid use is critical, which aids in scar modulation. So the last case, 51-year-old male diagnosed with viral keratitis in left eye elsewhere. He was using over-the-counter steroid antibiotic formulation since 3 years. So he had presented to us with this geographical ulcer. As soon as we stopped the steroids, he got another infective ulcer episode. Scrape was negative, but then we had put him on antifungals, and his hypopyon, the ulcer was worsening. But later on, he was put on antifungals as well as amikacin. All the antimicrobials were going in half an hourly and 1 hourly initially. That's why he was not responding. As soon as we tapered the antibacterials and put him on antifungals alone, that is amphotericin, he started responding to medications. And this is how he's healing now. So lesson learned number 4, polytherapy targeting multiple organisms is not the way to go. It reduces penetration of the required antimicrobial, which in turn leads to ulcer progression. So now comes the main thing, how to differentiate between infectious and sterile infiltrates. Sterile infiltrates usually peripheral with lucid intervals in between, nil to minimal overlying epithelial defects associated with vascularization. Hypopyons are very rare and it's associated with poor lid margins. Viral keratitis, various types from epithelial to geographical ulcer to stromal endothelitis, and finally the end-stage healed viral keratitis. So this is the diagnostic approach. Document the findings always. Send samples for gram stain, KOH and culture. Start empirical therapy based on stain reports or clinical suspicion, whichever is available immediately. And then if fungal hyphae is present, start the patient on antifungal therapy. Gram stain, if the organisms are isolated, and if the patient is already responding to the empirical therapy, continue the same. If not, change according to culture sensitivity. If the gram stain didn't isolate any organism and if the ulcer is less than 2 millimeters in periphery, superficial and not involving visual axis, start the patient on monotherapy, most commonly fluoroquinolones. More than 2 mm central ulcers with mid to deep stromal and involving visual axis, start the patient on combination or on fortified medications. So these are the various topical antibiotics which can be started for bacterial keratitis depending upon the gram positive or gram negative characteristics. So this is the TST protocol which is usually followed for fungal keratitis, which is targeted topical and systemic therapy given by Namada Sharma et al. Treatment protocol for herpes keratitis, which was given by Head's trial. And finally, the take-home message is, though the diagnosis of microbial keratitis is quite challenging, the art can be mastered with experience. Detailed clinical history is very crucial. Corneal scraping is to be done at all times possible. Microbiological and clinical diagnosis goes hand in hand. Beware of confounders. Cocktail treatments, steroid use, antibiotic resistance, and use of native medication should be always kept in mind. Knowing when to refer the patient to higher centers is extremely important. Thank you.
An important announcement, packed lunch boxes are available in Senate Hall. So those of you who are leaving early before lunch can collect it from there.
Thank you, Dr. Veena. Coming on to the next discussion, I'll be dealing about immune keratitis, how to go about it in an algorithmic approach. So the objective of this presentation will be how to differentiate between an immune and infectious keratitis, how to apply triaging questions or pathways so as to decide whether it is purely immunological or there is infective pathology underlying it, how to start first-line therapy safely so that you get a response in the follow-up, and also know the red flag signs, when to change your treatment, when to stop steroid, when to start steroid with an antibiotic or antiviral. So immune keratitis is usually a pattern diagnosis. It's an non-infectious pathology with an immune-mediated inflammation happening in the cornea. It can be post-infectious, that is the body is having an immunological reaction to the antigen or particles secreted by the organism as such, or purely autoimmune diseases can have an immunological symptom in the form of keratitis. Post-infectious causes, the most common being marginal keratitis. Then there is flictanular keratitis also. Viral infections are prone to have immunological pathology, and immune keratitis is common. Interstitial keratitis, even though very rare nowadays, that has also been a cause of immune keratitis. Another most common is the one associated with systemic diseases, that is PUK. When you have ruled out all the causes, then in peripheral ulcers, our diagnosis becomes Moorens. So what is the need? The need is because we are using steroids in most of these patients. But if there is an underlying infection, the use of these steroids can flare up that occult infection. And in PUK cases, inadvertent or non-judicious use can lead to perforation melt, and the need to referral might be delayed. Different set of systemic medications need to be started depending on the underlying etiology. For all these purposes, we need an algorithmic approach. So what are the clues from history that will help us in identifying what is the underlying cause? If the patient comes with a keratitis-like picture and has a definite history of trauma followed by eye rubbing or use of over-the-counter medications like steroid drops, think in terms of an infective pathology. If the patient also has a history of contact lens wear, then also the infection is more likely to be, depending on the clinical presentation, likely to be infectious depending on the symptom severity. And contact lens can also give us peripheral sterile infiltrates that you have to differentiate clinically. Any previous history of similar episodes have to be checked. Blepharitis, if associated, then think in terms of marginal keratitis. If there is previous history of similar infection, you can have suspicion of HSV in your mind. Autoimmune disease, if it's positive in any of the family member or if the patient itself is having recurrent oral ulcers or symptoms in that particular group of disorder, then suspect PUK or Moran's. History of TB or syphilis, think in terms of interstitial keratitis. So the clinical features, when there is an infection, the patient will be more symptomatic. There will be severe pain, redness, discharge, lid edema, and blurring of vision. And on examination, we will be finding an epithelial defect with associated infiltrate. Abscess can be there. Feathery satellite lesions if it's fungal. There can be AC reaction, hypopion formation. Whereas in immune cases, the symptoms will be slightly on the milder side. One, because in HSV patients, the sensations are reduced. And another because as such, the reaction is happening in the stromal level. So mild to moderate pain, no severe blurring of vision. Most likely it will be in the periphery, so vision will not be that much affected. Patient will be complaining of a foreign body sensation, photophobia, and also the redness might be localized. And on examination, we will be usually seeing a peripheral arcuate infiltrate. There can be a clear zone with the limbus, minimal epithelial defects, and the larger stromal lesion will give us a hint that it is less likely to be infectious. So when a keratitis patient come, if you get clues from the history, tailor your investigations in that way. If there is inconclusive evidence from the history, you will have to do a set of investigations to rule out which is the immunological pathology underlying. In that, you will have to also check for syphilis, TB, other viral infections which can have a immune reaction in the cornea. Basic blood investigation has also to be checked. If you suspect that still there can be some infectious components, scraping cannot be overlooked. You have to do scraping also. In spite of everything you do, you don't get a diagnosis and the lesion is peripheral, then suspect Moran's. So the peripheral lesions can be marginal keratitis. It's an immune reaction to Staphylococcus bacteria. It's a type 3 reaction in which immune complexes are formed and deposited against staphylococcal antigen in the peripheral corneal stroma. It can be in the form of infiltrates in the stroma, and if left untreated, it can coalesce and form a marginal ulcer. So its chain of pearl-like appearance is typical. There will be a 1 to 2 mm parallel to the limbus, the lesions will be. There will be clear margin of healthy cornea. Management is to have lid hygiene, hot fomentation, topical antibiotic ointment. Steroids are the best for treatment. But then also you have to give it under an antibiotic cover. Oral doxycycline for 1 or 2 weeks is also recommended. PUK, it's a destructive inflammatory disease of the juxtalimbal cornea. There is a crescent-shaped stromal thinning. There will be an overlying epithelial defect. Complex interplay of factors including both host autoimmunity and the particular features of the limbus. Because of the anatomical special features of the limbus results in PUK. So the etiology can be ocular cause and systemic cause. In ocular, infectious, non-infectious causes, and in systemic, There can be infections and non-infectious. This rheumatoid arthritis, ANCA-associated vasculitis, SLE, etc. are the commonest cause of PUK that we come across in our clinics. So how to manage? If you feel that it's purely an immune etiology and there is associated blepharitis, think in terms of marginal keratitis. There is no blepharitis, suspect PUK. Start the treatment, simultaneously send for a rheumatology evaluation also. If you feel that it's infectious, then send for scraping. If it is healing well, manage medically with the antibiotics. Non-healing, there is impending perforation. Also think in terms of PUK and also manage the perforation with surgical methods, which will be explained later. So if there is underlying systemic autoimmune diseases, local therapy can be given in the form of lubricants, as basic pathology will be severe dry eye. Give low dose antibiotics to prevent secondary bacterial infection. The role of topical steroids is controversial. You can start but keep on close follow-up. Topical cyclosporin is being studied as an adjunct role. In cases of where we can have to use steroids, can we use cyclosporin as an alternative? Systemic therapy has to be started. You can start doxycycline itself. Systemic corticosteroid or steroid sparing agents under the supervision of a rheumatologist needs to be started. Or if TB or syphilis is diagnosed, then treat systemic infection under a physician's guidance. Aggressive systemic immunosuppression is the treatment for PUK. Topical steroids, the role is controversial. It can increase the chance of perforation. Always send for rheumatology consultation in patients with high suspicion. In stromal keratitis, it can be either interstitial keratitis or viral stromal keratitis. Interstitial keratitis, the overall incidence is very rare nowadays. The commonest etiology still is syphilis and viral. Multiple organisms can have an immune reaction in the stroma. So the same thing holds true for stromal keratitis also, in interstitial keratitis also. There will be associated conjunctival injection, corneal haze, mainly stromal. Usually the epithelium is intact. There will be stromal neovascularization, and in certain cases, ghost vessels if old infection can be seen. If active, the treatment is topical steroids. If viral etiology is suspected, if sensations are less, or if the patient gives a history of past similar episode, start on antivirals. Treat the underlying systemic infection depending on the test results. Coming on to HSV, which is the most common cause of stromal keratitis that we come across in our practice. Out of all the types of keratitis caused by virus, immune stromal is the one, and endothelial ones are purely immunological. The rest of the ones, there is active viral multiplication happening in the cornea. So in immune stromal keratitis by HSV, it's a type 3 immune-mediated reaction. There is retained viral antigens in the cornea, which is causing the trigger for inflammation. So you can have an immune ring of Wesley also. There can be lipid deposition. There can be vascularization of stroma. Management is typical. The standard management is topical corticosteroid under antibiotic cover. If there is associated epithelial keratitis, you can give antivirals also. Always start for stromal keratitis acyclovir 400 mg 2 times a day. The head study have given us the criteria for giving treatment for stromal keratitis. So in patients where only antivirals were used, they found that the addition of prednisolone definitely had a role in faster healing of stromal keratitis. So in stromal viral keratitis, treatment should include steroid drops under antibiotic cover. If there is epithelial component, start antiviral treatment also. In those patients who are already on steroids and prednisolone, they found that the addition of oral acyclovir 5 times a day doesn't have a role. But you can always put that patient on 2 times a day in a prophylactic way to prevent further infection. It was found that there was 41% reduction of any chance of recurrence in such patients. Endothelitis is another cause. It can be disciform, diffuse or linear. In all types of endothelitis, your treatment should be topical steroids, oral steroids if there is severe inflammation. Oral antivirals has to be started. It has been found that there is role for starting 5 times a day for at least 3 weeks. In cases where endothelium and iris and trabecular meshwork is involved, topical antivirals if there is overlying epithelial involvement, secondary infection needs to be prevented with a broad spectrum antibiotic. So while using steroids, we have to find that it's a double-edged sword. There will be rapid response, patient will be responding well, but at any moment the virus can get reactivated and the patient can have epithelial disease and virus can invade and cause stromal necrosis. So always follow up the patient closely and you will have to keep the patient on long-term steroids. So the chances of cataract and glaucoma also needs to be taken care of. So pattern recognition, exclude infection, those are key. In PUK, systemic treatment is required, so you have to refer the patient timely. In HSV keratitis, give steroid plus antiviral under antibiotic cover, treat leads wherever necessary, use steroid drops judiciously for a better outcome. Thank you.
So I'll be dealing with the surgical strategies in keratitis, scalpel the savior. So oftentimes we'll be able to manage most of the keratitis on medical management, but we will have to convert it to a surgical therapy whenever it's required. So why do we need surgical treatment in case of keratitis? First would be a perforate keratitis. Whenever you get a perforated keratitis, you need to restore the integrity of the globe, and it needs to be performed as early as possible so that further damage can be prevented. And surgical strategies include glue BCL or Tenen-Spatzgraft or penetrating keratoplasty. And sometimes you need to do keratoplasty to prevent further melt or to prevent endophthalmitis from happening. And it's an immediate eye saver measure in cases of keratitis. And the second indication would be a non-responsive or a poor response to medical management. Whenever you treat a keratitis, if you think that it is not responding adequately or it's progressing, then you need to convert it to a surgical therapy. So it halts the progression of infection despite maximal therapy, and it also prevents the eye from distorting. Like the anatomical success will be better, like preventing complications like secondary glaucoma, retinal detachment, choroidal detachments, and prevention of scarring also can be done with surgical management. So, as per the WHO definition, what is a non-healing microbial keratitis? Commonly, what we encounter is a bacterial and a fungal infection. In cases of bacterial keratitis, if it's not responding to your therapy, maximum medication or the adequate medication in 3 days, it's a non-healing ulcer in case of a bacterial keratitis. Whereas fungal, it's a slow-growing infection, so you have a little more time. Up to 1 week, you can wait if it's not responding to your treatment or the response is inadequate. It is called as a non-responsive fungal keratitis. So these are the plethora of surgical options available for a keratitis case. First would be an AC wash, which is a minimally invasive procedure. You are doing an AC wash with a fortified intracameral antibiotic or an antifungal, or you can add on an intrastromal injections in case of fungal keratitis. Next would be a glue and BCL therapy, where you are sealing the perforation. Along with that, you are adding some more antibacterial or antifungal effect in with glue. Third would be a Tenen-Spatzgraft, and fourth would be a full thickness penetrating keratoplasty. And in cases of immune keratitis, you can go ahead with conjunctival resection or resection. And last would be a Gunderson flap, where the visual prognosis is very poor. You can go ahead with Gunderson flap to alleviate pain and halt the progression of infection. So first would be AC wash with intracameral or intrastromal antibiotic and antifungals. So any case which is not responding, you can go ahead with a AC wash. And intrastromal as well as intracameral in case of fungal keratitis, deep stromal infiltrates, corneal endothelial plaques, or large hypopyon, you can think about AC wash. And if you don't have a culture positivity on scraping, so you need a microbiological tissue, then again you can go ahead with AC wash. You can take out the hypopyon, aspirate it, and then you can send again for culture. You might get a better yield and you will be able to treat it better. So fortified intracameral antibiotics commonly used as per the sensitivity, but commonly you can use ceftazidime, vancomycin, amikacin. And in case of fungal keratitis, you can use voriconazole or amphotericin B based on the organism which you have suspected or what you have got in the culture sensitivity report. And you can always repeat the intracameral or the AC wash after 48 to 72 hours in any case of keratitis which is not responding to your medical management. So intracameral antibiotics, many people have tried. Intrastromal also people have tried, but intrastromally antibiotics are not given. These are some of the intrastromal evidences, but intrastromal antibiotics are not generally given because it causes edema, it causes endothelial cell loss. So intrastromal is given mostly in cases of fungal keratitis only. For bacterial, you are giving intracameral. In intrastromal, why you need an intrastromal injection? Because the antifungal penetration is very less compared to an antibiotic, fortified antibiotic. So you need some targeted, as in case of the TST protocol as mentioned here. You are targeting on the intrastromal tissue. So any deep stromal infiltrates not responding to your topical antifungals, or if there is recurrence after epithelial healing, there is poor drug penetration, especially the natamycin drop, which you use as a suspension. If there is no epithelial defect, it is not going to penetrate into the corneal stroma. In such a case, you might have to go ahead with a voriconazole injection or amphotericin injection intrastromally. So in this intrastromal injection, you have to take care that you don't inject into the normal tissue. You have to inject into normal tissue. You should not seed by injecting into the infected tissue and then again into the normal tissue. So these are the cases where you should go for a intracameral as well as intrastromal injections. And next is supportive therapy. In case of medical management, often we ignore this supportive therapy, like adding on antifungals or adding on anti-inflammatory. So these are the things. Anti-inflammatory drugs and anti-glaucoma medications can always prevent perforation. If the IOP is high, even if you give the maximal medication, there can be melt and perforation. So adequate either systemic or topical anti-glaucoma medications has to be given if the IOP is high, or if you think that the inflammation is high and is going to have a high IOP rise. Management of perforated ulcers is based on the size of the perforation. If the perforation is very small, micro perforation, you can just place a BCL if the chamber is formed, or if the perforation is less than 3 and the chamber is shallow, there is active leak, then you can go ahead with a cyanoacrylate glue application or a Tenon's patch graft. Whereas in large perforation more than 3 mm, you need either a lamellar patch graft or a Tenon's patch graft or a therapeutic penetrating keratoplasty. Cyanoacrylate glue, it's for the small perforation, as I said, but in case of moderate perforation like 3 to 5 mm, you can use some advanced techniques like a sandwich technique. You can take out normal epithelium from the normal tissue and place it over the perforation and apply glue over that. That is the epithelium drape technique. Or the eye drape which you get, you can take out a 3 or 4 mm of eye drape, place it over the perforation and then apply glue over that. Okay. And in case of descemetocele also, you can use glue BCL therapy, but it's not FDA approved. It's an off-label use. Again, it has an added advantage of tectonic support as well as antifungal and antibacterial effect, more in cases of antifungal. So butyl and octyl cyanoacrylate is commercially available. So it can be applied by plug. The iris tissue has to be released. The chamber has to be formed either with a air, or you have to form with a viscoelastic. And then with a 26 gauge needle or a small Sinski hook or something, you have to apply a very thin layer just to cover the perforation and apply it and keep it for drying. And then you can place a BCL over that. And usually it heals around 6 to 8 weeks. It disintegrates by itself and you don't have to remove it. But if it's not getting disintegrated, you can always attempt a removal of glue BCL, taking up the patient to OT. Better not to do in the OPD, because you might have to reapply glue in the if it perforation reappears. Okay. And disadvantages of cyanoacrylate glue is it causes severe inflammation and vascularization. You need to cover up with a steroid drops. So this is a 16-year female patient with bacterial corneals are perforated on maximal topical therapy. She was on cefazolin and tobromycin. So it has perforated, and I've done a glubicil in this patient, and it healed well. At the end of around 8 weeks, she was 6-9 parts. Even though there is a central scarring, the patient has a nasal clear area. She has a reasonable vision. Especially in a young patient, you can avoid therapeutic penetrating keratoplasty in such patients with a glue-BCL. So this is another patient which has done very well with a glue-BCL. Tenon's patchcraft, if you're not confident with glue-BCL or if your glue is not available, you can go ahead with Tenon's patchcraft. Again, it's a biological tissue which you can take from the patient itself. The problem with Tenon's patchcraft is you will have to suture, you will have to glue with a fibrin glue, you will have to place BCL. It can dislodge. That is one thing. The perforation sometimes might not seal with a Tenon's patchcraft. You might have to add on cyanocolate glue also along with the Tenon's patchcraft, and it causes severe vascularization. It's a tectonic tissue which causes an opacity. So central Tenon's patchcraft, it's better you avoid it. Peripheral ones, always it's a good option compared to a glue BCL, because in cases of peripheral perforations, the glue dislodgement is more in cases of peripheral glue BCL compared to a central one. So if it's a peripheral one, Tenon's would be a preferred option compared to a glue BCL. So next is a lamella keratoplasty. There are multiple papers and evidence says that you can go ahead with lamella keratoplasty if it's progressing, but there is always a risk that interface infection and recurrence of infection with lamella keratoplasty. So not very commonly done, but if you think that you can manage with a DALC, you can do all that also if there is a cornea available at your center. So gold standard is for larger perforation, not responding to treatment, endophthalmitis, all these cases, you need to go ahead with a therapeutic penetrating keratoplasty only. So the goal is to clear 0.5 mm of clear cornea on either side of the infection, and you get a tissue for culture sensitivity so that you can add on post-operative antibiotic or antifungal or whichever medication you need to start post-operatively. You have to debride out all the necrotic tissue. You have to irrigate with antibiotic or antifungal if you have a culture in hand, or based on the clinical suspicion, you can give intracameral antibiotic or antifungal along with a therapeutic penetrating keratoplasty. So these are the various steps, and what are the things we should take care when you do a therapeutic penetrating keratoplasty. Always try to preserve the lens if it's clear, and whenever you are trying to take up a cataractous lens, don't you try to avoid expulsion. You try to avoid the posterior capsular rupture, and if there is rupture, you have to do a limited vitrectomy only, and you have to try to maintain the anterior posterior chamber integrity. So this is one of the case with a Pseudomonas keratitis which was resistant to all the antibacterials, only responsive to peptides. This was a patient with a 78-year-old male patient with glaucoma, progressive glaucoma on multiple anti-glaucoma medications. Post cataract surgery, 10 days had a surface infection. So initially he was started on amikacin thinking that it's a gram-negative infection, but the culture came out to be a multi-drug resistant Pseudomonas. We've added peptides, but it perforated in the very next day. So we did a peripheral patchcraft, and the patient is doing well with that. Next, this is another case where the patient had progressed. We did not get any microbiological evidence. This has progressed even with treatment. And finally, we had to do a penetrating keratoplasty. So you can see that the sequelae of waiting for a penetrating keratoplasty in this case, there is a pupillary membrane, there is cataract, there is glaucoma. So you have to time your penetrating keratoplasty. Don't think that you can treat all patients with medical management. You have to go ahead with penetrating keratoplasty. If it's not responding to maximal medications, even in 3 days, 5 days, you have to go ahead with surgery. Otherwise, it will end up with these sequelae. So these are some of the penetrating keratoplasty cases. Post-operatively, you can add steroids after epithelial healing in cases of bacterial infections. Fungal, you need to wait for at least 2 weeks for resolution, and then only you need to add on steroids in cases of fungal keratitis after penetrating keratoplasty. So sequelae of penetrating keratoplasty would be a graft failure, cataract, glaucoma, and phthisis bulbi. So our role is to find out cases which can progress into these situations, and we need to prevent as early as possible. So outcomes of therapeutic penetrating keratoplasty, I'm not going to deal with all these things. So the survival rate would be around 78.4% at 1 year by Tan et al. So survival of graft factors would be host factor, donor factors, and others. Last resort, in cases of poor prognosis, you can go ahead with Gunderson flap. You dissect out the tenons from the superior conjunctiva. You layer it over the cornea and cover it, and it heals well. This is one of the case with Gunderson flap with a poor prognosis, with end-stage glaucoma and keratitis, which we could do a Gunderson flap. Then in cases of immune keratitis, you can do conjunctival recession and resection to reduce the immune load. Amniotic membrane transplant, it has limited role, but in cases of infectious keratitis, once the epithelium is not healing, once the infection is under control, you can use it for control of the persistent epithelial defect, or if there is no biological tissue available, you can use it for closing the perforation. But the problem with amniotic membrane transplant is you will not be able to follow up the keratitis patient, you will not be able to assess the progression or recovery of keratitis if you put a AMG over the cornea. Last would be a tarsorrhaphy in cases of exposure keratitis with keratitis. Once you control the infection, you can always do a lateral or a peripheral, paramedian tarsorrhaphy to prevent further recurrences of infection. So that finishes my talk. I'll invite Rashmi for the final talk. So.
At the outset, I would like to thank Dr. Sharath for inviting. So I'll be speaking about recent advances and future directions in diagnosis and management of keratitis. I don't have any financial disclosures. So as we all know, keratitis is an important cause of visual impairment and blindness. And the earlier we make the diagnosis, the faster we can initiate the patient on appropriate therapy and better will be the outcome. So in the background of history taking and clinical examination, at present we mainly rely on the smear and the culture reports. So why do we need these alternative methods? Slit lamp, even though the principal diagnostic tool, infective organism cannot be seen, and not all the ulcers will have the characteristic clinical signs. Culture is the gold standard, but positive only in 57 to 67% cases. This is a study by the LVP group where they have analyzed a change in the trend in microbial keratitis, wherein we get more of culture negative keratitis these days. And why culture can be negative or smear cannot pick up the microorganisms is because of the inadequate sample material, a deeply seated lesion, delay in performing investigation, previous use of empirical antimicrobial treatment, or varying culture sensitivity. Also, there could be mixed infections, and we need these methods for monitoring of treatment also. So what are the alternatives? In imaging, we have in vivo confocal microscopy. In the diagnostic molecular methods, we have PCR, metagenomic next generation sequencing, mass spectrometry, and of course, artificial intelligence. So let's delve into these one by one. In vivo confocal microscopy can look through all the layers of cornea. The three main conditions where we can use IVCM is fungal, acanthamoebal, and microsporidia. In fungus, most commonly we see is Fusarium and Aspergillus. Also, IVCM can be used for monitoring of therapy. This is a study where confocal microscopy was used in diagnosis of Pythium keratitis. What are the limitations with IVCM? It is user dependent, requires a skilled operator, requires patient cooperation. The field of view is small. The objective has to be moved all around the cornea in order to detect the organism. Again, interpretation requires an experienced viewer. Dense corneal infiltrator scarring can preclude tissue penetration, and currently bacteria and viruses are not visible through IVCM. Moving on to diagnostic molecular methods, they are highly sensitive, specific, rapid, and they're ideal for microorganisms whose culture is difficult, time-consuming, expensive, or unavailable. PCR, rapidly highly sensitive enzymatic assay, most commonly has been used in diagnosing and distinguishing different types of viral keratitis. Also, few reports of fungal and acanthamoeba. Various literature studies have shown sensitivity, specificity ranging up to 100%. There are a couple of modifications in PCR, which includes nested PCR, multiplex, and reverse transcriptase PCR. Moving on to clinical metagenomic next generation sequencing, it allows for rapid, massive parallel sequencing of DNA RNA. This has an increased efficiency and quality with reduced cost. It includes both long read sequencing and short read. So in long read, we'll do a whole genome sequencing, which has a higher resolution. It can study antimicrobial resistance. In short read, these are targeted amplicon sequencings. It has a rapid outcome, but reduced comprehensiveness than the whole genome sequencing. It can be, NGS is able to read positive results in culture negative IK, low infectious bioburden if there are infections with atypical organisms or fungi. It can sequence all types of bacteria, viruses, fungi, parasites, identify a new pathogen, and has a quick turnaround time. Mass spectrometry has an accurate quantitative analysis of biological samples, including the microorganisms, can rapidly resolve all the pathogens to species and subspecies level, identify rare organisms which are not well known or well defined, and it can detect mixed infections. So what are the pros and cons with these molecular methods? They are highly sensitive, specific, have a rapid turnaround time, reliable confirmation of unusual organisms, and can guide the treatment decisions. Whereas it can amplify only a targeted DNA segment. DNA can be detected even after a successful antimicrobial therapy, which can lead to confusion. And there are some false positive and false negative reports also. What are the challenges with these molecular methods? The cost, accessibility, requires an expert manpower in handling all these. It cannot quantify the organismal load. And the most important, it cannot differentiate between active versus latent and viable versus non-viable infection. Moving on to artificial intelligence, these are various articles which have been published in relation to microbial keratitis and AI. It's based on deep learning where we have to put a load of pictures into it and then it will perform high dimensional analysis to give us a diagnosis. So currently what it can do is based on a clinical picture, it can tell you whether it is infective or non-infective keratitis. It can classify that infective keratitis in bacterial, fungal. And based on algorithm and the pictures you have put, the accuracy can range between 70 to 90%. Recently, there are IVCM detection AIs which can detect fungal highway. What are the limitations in artificial intelligence? It may miss the diagnosis of less common or a more complex infectious keratitis. If you feed in poor quality pictures, diagnostic efficacy is going to be less. Again, the data set that goes into it has to be monitored. And second, it's based on only photographs for which the sample size, what is the amount of pictures we need to load has not been determined. Moving on to the management practices. Currently, we use topical medications primarily, which has got low bioavailability because of the tear film and the corneal barrier. Plus, the frequency at which we give leads to ocular surface toxicity. There is emergence of drug resistance and emergence of biofilms. So, due to these, we have to look for better options in future. What are those options now? Nanotechnology-based drug delivery. Here, nanomaterials act as carriers for the existing antibiotics. These materials itself can have antibacterial and bactericidal properties. What do? They will disrupt the cell membrane. They will prevent protein synthesis and generative oxidative stress in the microorganisms, which leads to their lysis. Next is contact lens based drug delivery. Here we have contact lens which are coated with the nanoparticles. They can be a possible targeted delivery option and it can reduce the tear film dilution effects. Microneedles, they are minimally invasive approach for a prolonged drug administration in chronic diseases. They have enhanced drug bioavailability and it can overcome the physiological barriers, biofilm obstacles. Liposomes, again, they are small lipid vesicles with a central aqueous compartment. They have an excellent adhesion to the cornea and they have increased corneal permeability. But the only disadvantage is they have low stability and limited loading capacity. The other advances still in the experimental stages are plasma therapy, phage therapy, gene therapy, and probiotic therapy. Moving on to CXL, PAC-CXL, what is the basis of using CXL in microbial keratitis? Both riboflavin and UVA has known to be shown antimicrobial properties. There is strengthening of the corneal collagen against degradation by the collagenolalytic enzymes, and riboflavin has anti-inflammatory and pain-relieving effects. So what has been seen in the previous studies? Yes, it can expedite resolution in bacterial keratitis in terms of infiltrate and the time taken to complete healing. But there is uncertainty regarding the effectiveness and safety in treatment of keratitis. It's, in acanthamoeba, there has been contradicting evidence between in vitro and clinical studies, and CXL is contraindicated in viral keratitis. Moving on to PDAT, where we use rose bengal. A green light is exposed to a rose bengal soaked tissue. This can be currently it is only in experimental stages and has been used as an adjunctive treatment in fungal and certain acanthamoeba cases, but it needs more evidence in the form of randomized controlled trials. So all these new techniques are promising. They can improve the diagnosis and give us a targeted therapy, but we need more evidence before applying these into our clinics. Thank you.